So I'll tell you a little bit about the talk that I gave. I tried to, one, just introduce the concept of MPNs in pediatric and young patients to folks who may not know that it happens, because it does, and highlight some things about diseases in younger patients. Certainly, we see that ET is the most common type of MPN in young patients. We also see that triple negative disease, so not having a driver mutation in JAK2, CALR, or MPL, is more common in young patients than it is in older patients. We know that there's some challenges in making the right diagnosis in kids. They have different normal values for things like hemoglobin, hematocrit, and red cell count. So really thinking about whether or not diagnostic criteria designed for adults always fit perfectly to kids can be tricky. Thinking about thromboses in young patients, so we know that those happen, and we were able to present some data from our group in collaboration with others showing that both polycythemia vera type and JAK2 V617F mutation are associated with blood clots in our youngest patients. And then just reminding people that disease transformation does occur. Thankfully, we don't really see AML in childhood related to MPNs, but we do see transformation to myelofibrosis. And I shared some data from a nice review that was done recently about more adolescent and young adult patients. So that was some of the background I shared during the talk. And then just some considerations for treatment in young patients, thinking about things like aspirin in patients with JAK2 mutation, which is something I do frequently. Some of the challenges related to phlebotomy in young patients, especially when iron deficiency is already a problem in a lot of kids with PV, and pediatricians don't like iron deficiency in our patients. And then just thinking about discussion of types of treatments. And then something else I brought up during the session was a little bit about the concept of transition of care from the pediatric world to adult medicine and things we can do to help ease that transition. And I'm working with an international collaborative group to look into that. And we developed what we consider a toolkit, which includes an educational checklist for pediatric providers who maybe don't have a lot of experience with MPNs, or even adult providers who don't see a lot of older adolescents and young adults with MPNs, to help guide your education of your patients. We developed a transition readiness assessment tool that was based on a model that ASH developed as a general tool that could be modified for MPNs. And then we thought it would be helpful if there was not a real guideline, but just a consensus statement of some treatment points and diagnostic elements that we could agree upon as a group of pediatric and adult providers taking care of people with MPNs. So things like not treating a platelet count just because it's elevated, trying to avoid cytoreduction in settings where we don't think it's needed, thinking about doing a bone marrow in these patients, because as we said, there can be some challenges in making the diagnosis. And then we as a group did agree that interferon was our preferred first-line agent for patients when it was available and when it seemed appropriate. So that was pretty much a summary of the talk.